Welcome back to the Deep Dive. Today we are jumping right into one of the most time-critical events in all of emergency medicine, status epilepticus, or SE.
Yeah, and this isn't just a patient having a seizure. This is a situation where the clock is literally counting down to, well, irreversible neurological damage.
So let's define that. Clinically, what is status epilepticus?
It's when a seizure lasts for more than 5 minutes, or, and this is key, when a patient has multiple seizures without really, fully waking up and regaining consciousness in between them.
And we need to get into the mechanism of injury right away. Why is this such a red alert? We hear this term excitotoxicity. What does that actually mean for the patient's brain?
It means neuronal death. Simple as that. When a seizure goes on, the neurons are just firing constantly, releasing this massive flood of excitatory neurotransmitters.
And that just burns them out.
It literally overstimulates the brain cells to the point where they die. So prolonged SAC, it's associated with incredibly high morbidity and mortality. The mission is totally unambiguous. You have to stop that seizure, and you have to stop that clock.
Which is why there's this highly structured stage protocol. We can't hesitate, but we also can't just, rush in blindly.
Exactly. You're doing 3 things at once: stabilizing the patient, investigating the cause, and giving anti-seizure medications, ASMs, all on a really strict timeline.
It's a protocol built on failure, in a way.
It is. It's actually a beautifully designed system because it forces you to act. You start with the fastest, safest agents, and you only escalate, and you escalate aggressively when the previous step fails.
Okay, so let's set that clock to 0. The guidelines break this race down into these critical stages: emergent, urgent, and then refractory.
Right. And that first phase, 0 to 5 minutes, is the emergent treatment. Your first priority here is just immediate patient safety. Airway, breathing, circulation, the ABCs.
So you're protecting them from injury, making sure their airway is open.
Yep. Get them on their side, give them high-flow oxygen, and get them on monitors immediately. We're talking heart rate, blood pressure, O2 sats, and ECG, all of it.
And while all that's happening, we're trying to get access and data. Right.
Absolutely. You're
Okay.
trying to secure 2 large-bore IV lines. You're going to need them. And you're noting the exact time the seizure started. But the one non-negotiable step, the first thing you have to do, is check a fingerstick glucose.
Why is that glucose check so critical? More than anything else right at that moment.
Because if the patient is hypoglycemic, you might have just found a completely correctable cause that could stop the seizure right then and there.
It's the easiest possible fix.
It's the easiest fix. For an adult, you'd give 50 millivieles of 50% dextrose. For a kid, maybe 2 to 4 millivols per kilo of 25% dextrose.
Okay, but what if you suspect, say, chronic alcohol use or malnutrition? There's a specific order of operations there, isn't there?
Oh, this is absolutely crucial. You must give 100 milligrams of thiamine the fief before you give the glucose.
Why before?
Because if you give glucose to someone who's thiamine deficient, you can actually precipitate a condition called Wernicke's encephalopathy, which is a devastating permanent neurological injury. So you're preventing harm while trying to stop the seizure.
Okay, so we're through the first 5 minutes. We've stabilized, we've checked and corrected for glucose. The clock hits minute 5, and we're into phase 2. Urgent treatment. This runs up to minute 20.
And this is the first-line pharmacological attack. We're using benzodiazepines.
The goal being just rapid seizure termination.
Exactly. You're leveraging their quick action on GABA receptors to just, calm everything down, to dampen that neuronal excitability.
The main choices here are lorazepam, midazolam, and diazepam. 4V is always what we want if we can get it.
4V is always preferred. It's the fastest. Lorazepam, usually about 4 milligrams, the 4V, is often the favorite.
And why is that?
It's highly lipophilic, so it crosses the blood-brain barrier really fast, but it also has a more sustained effect. It sticks around the brain longer than diazepam does.
But let's be realistic. In the chaos of an emergency, getting a good IV line into someone who's actively seizing, that can take precious minutes.
And those minutes are killing neurons. That delay is the enemy. And this is a key insight from the guidelines.
It is.
When you can't get IV access quickly, don't waste time. Intramuscular, intranasal, or even buccal midazolam, usually 10 milligrams, is demonstrably superior to just fumbling around trying to get a vein for 5E diazepam.
So it's a true first-line alternative.
Absolutely. So we give that first dose. If the seizure is still going after 5 minutes, you give a second dose of the same benzodiazepine. But by minute 20, if you've given 2 good doses and they're still seizing, we've officially failed step 1.
And we've just crossed a major clinical threshold, haven't we?
We have. This failure tells us that the seizure is resistant to GABA agents, so we have to shift gears immediately. We're into phase 3, the control phase, from minute 20 to 40.
What's the mission now?
We have to load a full therapeutic dose of a non-benzodiazepine ASM.
Okay, let's talk about those second-line options. What are the main choices?
We have 3 big players here: levetiracetam, valproic acid, and fosphenytoin.
And if speed of infusion and overall safety are the main concerns, which two tend to be favored?
Well, levetiracetam, which people often call LEV, is loaded at 60 milligrams per kilogram Terva, up to a max of 4,500 milligrams.
And valproic acid.
Or VPA, yeah. That's loaded at 40 milligrams per kilogram Anaven-Terva, with a max of 3,000 milligrams. The big advantage for both LEV and VPA is that they are generally much safer to infuse rapidly. You need less intense cardiac monitoring.
Which brings us to fosphenytoin. It's effective, but it comes with a pretty serious catch, doesn't it? The administration is slow, and slowness is not our friend here.
This is the first major trade-off in the protocol. Fosphenytoin, or FOS-PHT, is dosed at 20 milligrams of phenytoin equivalents per kilogram. But the critical, absolutely non-negotiable caution is the infusion rate.
It has to be slow.
It has to be at or below 150 milligrams of PE per minute.
Why is that rate so important in a crisis where every minute counts?
Because faster infusion is directly cardiotoxic. If you push fosphenytoin too fast, you risk causing severe, rapid-onset hypotension and potentially fatal arrhythmias.
So you're in a desperate race to save the brain, but if you push too hard, you could crash the heart.
You crash the whole circulatory system. It forces this agonizing caution, which is a big reason why LEV and VPA are often preferred. They're just less complicated to give quickly.
So while that second-line drug is infusing over that 20 to 40-minute window, the investigation has to ramp up, right? What are we looking for in labs and imaging?
Right, you're trying to pinpoint the why. The etiology. So a full set of labs goes out: CBC, BMP, liver functions, MAG, calcium phosphorus, CK, a blood gas, a tox screen.
And you'd check levels of any anti-epileptic drugs they were already on.
Of course. And crucially, you have to be thinking about imaging a CT or MRI to look for a structural cause: a bleed, a stroke, a tumor, or even signs of a bad infection like encephalitis. That infusion time is your diagnostic window.
Okay, we've just hit the 40-minute mark. We've given benzos. We've given a full load of a second-line agent like levetiracetam, and the patient is still seizing.
We have failed again. And now we're moving into the most dangerous phase: refractory status epilepticus, or RSE.
And that means a whole different level of care.
It means we are going straight to the intensive care unit, the ICU.
What are the immediate changes we have to make to support the patient, given the kind of drugs we're about to use?
We're moving to heavy anesthetic agents, and those carry a huge risk of respiratory depression and apnea, so urgent intubation and mechanical ventilation are required. They can't protect their own airway on these drugs.
And the most important monitoring change.
Continuous EEG monitoring, CEEG. It is absolutely mandatory.
Why is that so crucial now?
Because at this level of suppression, the seizure activity often becomes non-convulsive. The patient stops shaking, but their brain is still seizing. Without a CEG, you are flying completely blind.
Let's talk about these third-line agents, the anesthetics. These aren't just one-time doses, are they?
No, these are continuous infusions, and they are titrated specifically using that CEG data. We're aiming for a pattern on the EEG called burst suppression.
And what is that?
It's a pattern that shows periods of extreme electrical silence in the brain, punctuated by these little bursts of activity. It confirms we've chemically shut the brain down enough to finally break that seizure cycle.
What are the main anesthetic agents used to get to that state?
We really rely on 3: midazolam, propofol, and then pentobarbital, or thiopentol. Midazolam is run as a continuous infusion, usually between 0.1 to 2.0 milligrams per kilogram per hour.
Propofol is also incredibly effective, but it comes with a really terrifying warning label.
It does. Propofol is infused between 20 and 100 micrograms per kilogram per minute. The crucial thing you have to monitor for is something called propofol infusion syndrome.
And that can be catastrophic.
It can, especially with high doses or prolonged use. It can cause metabolic acidosis, muscle breakdown, kidney failure, and severe heart failure. It's a huge risk-benefit calculation for the medical team.
And the other option, pentobarbital.
Very effective at stopping seizures, but it's a potent vasodilator. It's associated with the highest risk of severe persistent hypotension. You often need to run aggressive vasopressors just to keep the patient's blood pressure up.
And just to be clear, Even while we're running these powerful anesthetic infusions, we don't stop the second-line drug we started earlier, do we?
No, absolutely not. That anesthetic is like a powerful temporary bandage. The patient has to be maintained on therapeutic levels of that baseline ASM, that levetiracetam or phosphonetoin, to prevent the seizures from just coming right back when you try to wean the anesthetic.
It's fascinating because while the focus is on stopping the fire, the sources constantly emphasize this parallel track, finding the cause. How critical is the etiology to the patient's outcome?
It is the single biggest predictor of their outcome. If we can find and reverse the cause, let's say it's a severe electrolyte problem, the prognosis can be excellent. If the SE is from, a catastrophic stroke or an unknown cause, the outlook is much, much worse.
There's a great mnemonic the sources use to remember the common causes we need to hunt for. AEIOUT. Can you break that down?
Yeah, it's the essential checklist. A is for anti-epileptic drug noncompliance or withdrawal. E is for electrolyte or metabolic issues, like bad hypoglycemia or hyponatremia.
That would be infection.
Infection, right? Meningitis, encephalitis. O is for oxygen or vascular problems, hypoxia or stroke. U is for unknown causes or uremia from kidney failure. And finally, T is for trauma, tumor, or toxins.
Now, what happens if the seizure continues or comes back even after 24 hours of being maximally suppressed with these anesthetics? We cross to another category, don't we?
We do. Superrefractory status epilepticus, or SRSE. And this is the point of, frankly, clinical desperation. It's incredibly complex.
What does that mean? What's left in the toolbox?
It means we have to think outside the conventional mechanisms. We might introduce a drug like ketamine. The important thing about ketamine is that it's an NMDA receptor antagonist. It's a completely different pathway than the GABA drugs or the sodium channel blockers we've been using.
We're targeting a whole different system.
A different excitatory pathway, exactly. And
Yeah.
beyond that, we start thinking about more radical therapies.
Such as?
Well, if you suspect an underlying autoimmune or inflammatory process, you might pivot to immunotherapy. High-dose steroids, IVI, even plasma exchange.
And what else?
You might load a third or even a fourth traditional ASM, like topiramate or lacosamide. And in some select cases, even the ketogenic diet, a very high-fat, low-carb diet, is used to try and alter brain metabolism to gain control.
That shift really shows how the specific suspected cause starts to drive the treatment in these most resistant cases.
It has to. And just to mention it, therapeutic hypothermia is sometimes discussed, but the evidence is really limited and it comes with a lot of its own problems, so it's pretty controversial.
Let's circle back to the practical difficulties of managing these patients in the RSE phase. You mentioned hypotension is a huge risk.
It's a massive risk. You need continuous, minute-by-minute hemodynamic monitoring, not just because the seizure is stressful, but because all our main drugs, midazolam, propofol, pentobarbital, are vasodilators and cardiodepressants.
So the challenge isn't just watching the numbers.
No, it's aggressively managing fluids and vasopressor drips to stop the patient's blood pressure from crashing while you're trying to save their brain.
Okay, let's say we've been successful. The patient has been seizure-free for 24 to 48 hours, confirmed on the CEG. How do we safely wake them up from this coma?
The weaning process is incredibly delicate. You taper that anesthetic infusion very, very slowly, often over hours or even a full day.
And only after that seizure-free window has been met.
Only after that 24 to 48-hour benchmark is confirmed on the EEG. And all the while, they have to remain fully loaded on their long-term ASM, like levetiracetam.
And what happens if the seizures come back during that taper?
That is the nightmare scenario. It's a huge rebound. If the CEEG shows any return of seizure activity, you have to immediately go right back up to the full anesthetic infusion. And that recurrence means the brain needs an even longer period of suppression before you can dare to try weaning again.
This has been an incredibly detailed and very high-stakes deep dive. We've gone from that initial stabilization to the crucial choice of benzodiazepines, the escalation to second-line agents, and finally crossing that 40-minute line into refractory SE, which requires intubation, CEEG, and anesthetics.
And the one thread connecting it all is that two-pronged attack. You have aggressive, time-sensitive pharmacology to stop the excitotoxicity, and that's running at the same time as an aggressive investigation using tools like AEIOUT to find the underlying cause. Because stopping today's seizure doesn't mean much if you haven't solved the problem for tomorrow.
Which brings us to a final thought for you, our listener, to consider. When you reach the stage of superrefractory status epilepticus, you start deploying these non-conventional therapies, drugs like ketamine or interventions like immunotherapy. Considering these are only used after the failure of our most powerful anesthetics, what is this willingness to abandon the established protocol and target entirely different biological pathways? Tell us about the sheer adaptability and perhaps desperation required to manage the most profound and resistant forms of neuronal instability.